Let's say someone had a post-operative pancreatic leak. What do? Well, it often actually resolves on its own with conservative management. The reason is because when you have the surgery, surgical drains are going to be there to prevent any pancreatic excretions from really accumulating in the peritoneum. Now, if you end up having high drain output of this pancreatic fluid and it's too much for the surgical drains to completely excrete it out, you can definitely develop primary metabolic acidosis. Now, the patient will have a low pH, their bicarb will be low as well, and you'll also have compensatory respiratory alkalosis, so your PCO2 will be low. We call this NAGMA, or non-anion gap metabolic acidosis, and this is usually the result of loss of bicarbonate. How does this happen in pancreatic leak? Well, the pancreatic fluid itself is very high in bicarbonate, so it makes sense. To make it even more intuitive, bicarbonate is basic and it neutralizes the highly acidic chyme that comes from the stomach when you're trying to have enzymatic digestion of food in the small intestine. Now, if you think about bicarbonate contributing to a lot of the volume inside the small intestine, you should also be thinking that if a patient has an ileostomy tube or if they have an enterocutaneous fistula, if they have some type of large volume loss going away from the small intestine, then think about non-anion gap metabolic acidosis as a complication. Remember this, if you lose bicarbonate, your body will naturally try to increase serum chloride. Think of it as two negative anions inside your body, one trying to maintain the electronegative balance inside your body. This type of NAGMA is hyperchloremic acidosis. What other things cause NAGMA? Severe diarrhea, renal tubular acidosis, excess saline infusions, intestinal or pancreatic fistulas like I mentioned earlier, and also carbonic anhydrase inhibitors or mineralocorticoid receptor antagonists, and these are both diuretics. Think about the diarrhea and the pancreatic fistula or intestinal fistulas like I mentioned earlier because of the high volume concentration of bicarbonate inside the GI tract. In RTA, you have renal loss of bicarbonate, which naturally will cause this non-anion gap metabolic acidosis because again, you can compensate with the increase in chloride. When you have an excess of normal saline infusion, you produce a hyperchloremic metabolic acidosis because in normal saline, which is 0.9%, you have an equimolar concentration of sodium and chloride, which is around 153 millimoles per liter. The high amounts of chloride from the saline infusion actually forces the bicarbonate to move intracellularly to maintain ionic equilibrium, and then this can cause a difference in the pH buffering system, which in the end leads to a net acidosis. The carbonic anhydrase inhibitors affect the kidneys, the eyes, the brain, and also has acid-base effects. Now, in the kidney, which is most important, in the proximal convoluted tubule, you have increased hydrogen reabsorption and inhibition of the sodium-hydrogen exchanger. What happens is you increase the amount of bicarbonate that you pee out along with sodium. When this happens, you have compensatory hyperventilation sometimes and disinhibition of certain central chemoreceptors and increased oxygenation. In the end, you have this proximal renal tubular acidosis, which is the same hyperchloremic non-anion gap metabolic acidosis that I mentioned earlier. You then have your mineralocorticoid receptor antagonists. These are like spironolactone or apelrenone, and the way that these work is through competitively binding the mineralocorticoid receptors in the late distal convoluted tubule. The effects of this eventually is decreased sodium reabsorption and increased potassium excretion. This in the end causes diuresis. Now, the reason why you have acidosis is because you have decreased hydrogen excretion as well. So as the hydrogen builds up inside your body, you have a metabolic acidosis that can occur.